One of the keys to pain management is understanding. Understanding why the body is doing what it's doing. Why one person with back pain is debilitated, bent bound, whilst another person with back pain is getting on with their day, getting to work, living their life. Why is it so different for each and every person? And why is it so important to have an understanding? Well, a critical key part of pain management is to actually give the person with the pain information. Because the moment you start understanding why your body is doing what it's doing is the moment you start taking back control again. And I've seen it over and over again over the many years I've been practicing. So for example, I saw a guy recently who was a young man. He had a family, he brought his daughter in, he was looking after her for that day, and he had back pain, and he was very limited in what he can do because of the back pain. He'd stopped working because of the back pain. He was on a bit of opioid medication for the back pain, and the medication was just causing side effects. The first consultation that we had, which is a very important part of pain management, understanding the pain, the history, what the pain is doing to somebody, and setting out a treatment plan. Part of that first consultation involves educating the person as to what's going on, why it's going on, and what the pathway forward can look like. And this first consultation with this guy merely gave him information. We talked a little bit about some mild medications that can be used for back spasms and cramps, non-opioid based medications, but we talked about movement. We talked about the boom-bust cycle of chronic pain. We talked about how he can get his body moving again. We talked about how safe it is to move your body, and that was a key light bulb moment for him. He said, "Hang on a sec, doc. So you're saying to me that it's okay to move my body, but I thought I was damaging myself." And I said, "No, you are not damaging yourself. Pain does not mean damage. Chronic pain does not mean damage." And I could see the light bulb going off, and he said, "Right, I get it." And the follow-up consultation, a number of weeks later, not a long time, a number of short weeks later, he was a completely different person. He'd weaned down and stopped his opioids. He had used the medication to help him with his pain, and he was back exercising again. Not at a high level, but certainly doing more than he was doing before that first important consultation. So it's important to understand your body. It is important to understand what is going on in your body, and hence this discussion is going to be about understanding pain. And there are many aspects to understand. This is just a single point to get across, and that is, what is nociception? What is pain? Are they the same thing? Why are they so different? That's your brain. It's remarkable. It is fantastic. There are 4 billion neurons throughout your brain and your body. And if you think about that, why everyone is so different, and everyone is different, and your pain is like a fingerprint. It is absolutely unique to you. There is no back pain that is the same between one person and another. So, nociception. Nociception is what we call a physiological process. It's where a noxious stimuli, a painful stimulus, is merely encoded. So in other words, I prick my finger, I squeeze my finger, I burn my finger. I cause either pressure, I either cause trauma, so I break the skin, or I cause some other injury to my finger, and the receptors, what we call nociceptors, in that area pick up the change in that environment and sends a signal down the nerve to my spinal cord. That is nociception. It is the body encoding a stimulus. That's it. We could reproduce nociception in a laboratory. Anyone with a nervous system and nociceptors can detect nociception. Now, pain effectively is when nociception reaches your brain. And that is completely different to nociception. So pain is not nociception. Pain, the definition, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So that's what happens when tissue damage, nociception, reaches the brain. And this is why I hear a lot of the patients we treat say, they told me it was in my brain. No one believes me that I have pain. And that is not true. Pain is real. Pain is absolutely real, and every person with chronic pain needs to be listened to. Their pain needs to be validated, and their pain needs to be discussed. And perhaps what they've been saying is the pain is not in your head. The pain is real. But somehow this information has come across in the wrong way, where somebody has said to you, and this is because, as I've mentioned in previous discussions, healthcare practitioners that are treating people with pain, most of them don't have the appropriate training in chronic pain assessment and management. And they might be misinterpreting what pain is. It's not your brain, it's the fact that when pain reaches your brain, you experience it in a different way. Or when should I say when nociception reaches your brain, you experience it in a different way. Let's look at nociception versus pain. They are two completely different processes. Nociception is merely the encoding of a noxious stimuli. So what that means is I hurt my finger, the neural network, the pain nerves need to carry that information from my finger to my spinal cord. That is nociception. It is just a relay. It is a signal. When that signal travels up the spinal cord, gets to the brain, and is interpreted by the top of the brain, the so-called cortex, that is pain. So pain occurs when nociception reaches the brain. And nociception generally is equal between a lot of people. It's a chemical, physiological process. Pain is not equal between different people. And that's why one back pain is not the same as another back pain. The definition of pain is an unpleasant sensory and emotional experience, and it's how you experience nociception, that signal, when it gets to your brain. And it's associated with actual or potential tissue damage. So, nociception. This is from Descartes' Treatise of Man from 1664, so a really long time ago, and it is almost true today, and I'll explain why. So he said that a painful stimulus, A, fire, had an effect on B, which is a nerve in the body. That B kind of pulled, traveled up the spine, which is C, to the base of the brain, which is D and E, and effectively opens a valve which releases demons from F. So effectively, in 1664, Descartes was describing what we now understand to be a rudimentary pain pathway. This is what it looks like. This is what we still understand today. You've got to have, we're talking about nociception, the encoding of a noxious stimuli, leg, foot, wherever it might be. It ascends through the neural network to the spinal cord. That is the spinal cord. From the spinal cord, it travels up to what we call the thalamus, which is the base of the brain, and then it's relayed again from the base of the brain to the top of the brain, the cortex. So there are three kind of relays. One from the finger to the spinal cord, number two from the spinal cord to the thalamus, and number three from the thalamus to the brain. But funnily enough, it's not a one-way system, it's a two-way system. Then what happens is the stimuli are encoded, experienced, perceived in the cortex, and then a relay signals travel downwards to have the necessary dampening effects. And these are the names of the areas, the periaqueductal gray, the raphe nucleus magnus, and a few other areas that we know are located in the brain that carry the signal downwards in an attempt to reduce, to balance out those painful stimuli. So this is what we call that element of homeostasis, balance between physiological processes in the body. Okay, but now I touch something hot and I pull away very quickly, and that's called the reflex arc. Now that is involuntary, and that's why part of this system is involuntary. So you get the relay from the noxious stimuli to the spinal cord before it travels up to the brain for you to experience that. There are many relays within the spinal cord, many synaptic connections within that spinal cord, and one of them connects to the muscles before it even travels straight up the brain, and your muscle withdraws. So that's called the reflex arc. So signal up to the spinal cord, immediate signal back down to the muscle saying pull away, it hurts. And then of course some of the signal is relayed up to the brain as well as when you experience pain. This is fascinating. That is why pain is so different between different people. This is just a diagram to represent what we call those free nerve endings, and that's what a nociceptor might look like. And that detects changes in the tissue, and those changes are relayed from the peripheral nervous system, the nerves in the arm, to the central nervous system, which is the spinal cord. And it's a complex area, clearly, but it's an important principle to understand. So we've got the nerve fibers that relay signals of pain are called A delta C fibers. They are relayed to the back of the spinal cord, the so-called dorsal horn. That's the first order of neuron. They then link via a number of relay systems, and of course we know one of them pulls your hand away, but then the other relay system travels up to the thalamus, and then from the thalamus to the outer aspects of the brain. And we know that some outer aspects of the brain are particularly important in that experience of pain. They're called so-called anterior cingulate cortex, prefrontal cortex, somatosensory cortex, insula, and a few other areas, amygdala, hippocampus, so these areas that people might be familiar with or have heard of. So that's up to the brain, and then you experience the pain in all its full color, and some might say glory, but really pain as that full experience, and then back down, relayed back down to the spinal cord to have an effect, to change behavior, to try and dampen down your pain, to try and cause that balance, that homeostasis. So for example, if you sit down for a long period of time, your bottom doesn't hurt because you've got these dampening down signals from the brain downwards switching off the pain signals. It's fascinating, and clearly there is a lot to it, but I just wanted to give you some ideas of why pain is so complex and what the difference between nociception is and pain is. And then the downward relay system, the downward suppressing system, comes from a number of key areas, and again they send signals down the spine to that area that is feeling nociception or has an input of nociception to try and balance it all out. Sometimes that balance gets lost. There is no downward suppression of pain, it's all just upward suppression of pain. Can lead to chronic pain. Sometimes that those upward signals become amplified. That's called sensitization. So sensitization is the amplification of pain. So some people might experience pressure on their wrist as pressure. Somebody with chronic pain, if you grab them and squeeze their wrist, they would experience more than pressure. It's an amplification of pain, and this is a physiological process that happens to people with chronic pain. So, when it gets to your brain, why is pain so different between different peoples? This is a fascinating study published in 2007 by Irene Tracy, and you can go and have a look at it yourself. There is the reference, the cerebral signature of pain perception and its modulation. Modulation is the downward suppression. The cerebral signature is different for each person. Your signature is different between people. Your fingerprint is different between different people. How you experience nociception, remember nociception, upward signal, how you experience that nociception is different because of these factors on your screen. Context. Context is so different. Some people, for example, on the battlefield, somebody is injured, shot. They will get up, do what they need to do, perhaps run away, pick up an injured team member and get to safety. They've been hurt, injured severely, they're in excruciating pain, but they still function at a high level. The context of pain is different compared to somebody that might be injured at work, in a workplace that is unsatisfactory or unsupportive. The context of the injury is completely different. Expectations. I expect to be hurt if I'm a soldier on the battlefield, whereas you go to work, you do not expect to be hurt. So completely different context of the injury, of the pain, of the experience. Have a look at mood. Well, everyone has different levels of mood. We know that pain and depression, anxiety, and what we call catastrophizing are closely related. If somebody is at risk of depression, anxiety, or catastrophizing, and they suffer some pain experience, their pain might be worse. It might be more severe. It might have a more profound effect on that person because they have some vulnerabilities. Or does pain trigger depression completely? Or does depression lead to somebody getting being vulnerable to suffering worse from pain? We don't know these answers, but we know they coexist. That's why managing a pain or painful stimuli doesn't always help unless you're affecting the mood, unless you're also addressing the mood, unless you're addressing the context. You're giving patients this information so it becomes clearer to them why they are experiencing the pain the way they are. Chemicals and structure are very important. So the chemical composition of your spine, of the so-called inflammatory soup, the chemicals within the spine, the receptors within the spine are so important. And we're all different. We have different genetic makeup. We have different levels of dopamine, different levels of endorphins, different levels of natural morphines. We have different responses to stimuli. Some of us are more prone to what we call maladaptive plasticity. So that means if I have a noxious stimuli, remember what I said, some people get sensitized, that stimuli becomes amplified, and that can cause higher sensations, higher levels of nociception, which in turn cause more pain experience. So it's a very complex system, as you can see, and this is all at the brain level. That downward modulation of pain can be affected in some people. So if you don't have that ability for balance and homeostasis, you get more nociception, more pain experience, less of turning that volume down, you're more prone to pain. And it's important as a pain specialist to tease out all the stuff for one individual sitting across with you. So you now understand why that first consultation is so important. And of course, the injury itself. Sometimes a severe injury can occur in the body, so an amputation, surgery, a broken bone, whatever it might be. The injury can be quite severe as to really switch on those nerves and that nociception process within the periphery wherever this injury occurs. So the injury is important. The type of injury, the severity of the injury is important. Not always, but absolutely can be important. And as I've mentioned before, you've got that peripheral sensitization where the nerves in the periphery of your body become heightened in sensitivity. You've got that central sensitization. The spinal cord becomes heightened in the way it receives and processes signals. And of course, you've got this amplification of all these processes that occur when it hits the brain, and you've got a completely different pain experience between one person and another for many different reasons. So, the definition of pain, we've already mentioned that an unpleasant sensory and emotional experience associated with tissue damage or potential tissue damage, because some people feel pain without damage of tissues, another discussion. But pain is a complex experience. It's personal. It is different for each and every person suffering pain, even though they've got the same type of pain or the same surgery or a similar nociceptive input. Their pain experience is completely different. So pain and nociception are different. Everyone learns about pain differently through their lives. It is your signature, it is your fingerprint, it is unique to you. People with pain need to be respected. That is a very important factor. People need to be heard. People need to have their pain acknowledged. People need to have respect in terms of pain and pain management. And we see it all too often. People are not believed. People with chronic pain are not believed by those around them, family, friends, work colleagues, even healthcare practitioners, doctors, allied health professionals. They just not believed. And it's through no fault of the person not believing, they just don't understand. Pain has adverse effects. We now understand this. It has effects on a person's function, on a person's biology. It has an effect on a person's psychology, and of course socially, or the wider social area around them, and it affects the community. The expression of pain is verbal. People tell you that they're suffering from pain. Sometimes they can show pain suffering in changes to behavior. Does that mean somebody that is unable to verbalize things to you doesn't feel pain? Somebody with cognitive decline or dementia? Well, the answer is no, of course not, but it takes a little bit more expertise to understand the pain. And clearly you've got to involve their family and friends and others around them to see if we can define a severity of pain, which is really difficult to do in some circumstances. Does that mean people that are not human experience pain? And in some instances we just don't know. We know that nociception occurs in animals because it is a physiological process that we can measure. Nociception, the carrying of an electrical impulse, a signal to the spinal cord or brain. But what happens when that signal gets to the brain? Our brains are different. Does that mean we experience pain differently? And the answer is most likely yes. So there are many aspects to pain that need clarification and understanding. This is another good final description of pain and how complex it is. Nociception starts, that leads to pain. Now we understand why this is, and those are two personal, private factors, your nociception and your pain. That's internal. But then that leads to suffering, which is external. People can see that. That leads to pain behaviors, reaching out, looking for help. That's external. And of course it leads to an effect on your surroundings and social environment. That is external. That can be seen, measured, viewed. So you can see by looking at John Luce's onions or layers of pain, you peel one layer to reveal another layer, why the pain experience is so different for each and every person. And that's what makes pain management so unique. It needs to be focused on the individual sitting in front of you.